Okay, so I recently reviewed the self-study by Chris Littlewood, so I thought it would be interesting to continue the theme and have a look at another pragmatic, multi-centered RCT, this one called the Swift Study by Deirdre Hurley. It's from 2015 and it was carried out in Ireland. It's called Supervised Walking in Comparison with Fitness Training for Chronic Back Pain in Physiotherapy. So I'm going to use the CASP tool to keep me on track, and we need to check if the trial addressed a clearly focused issue. So I've highlighted a few things to help me out as usual. The authors are just saying that there's been a few previous studies, but mostly on like treadmill or track walking rather than what they call kind of community-based walking. And there's not like a lot of evidence to support walking programs for back pain, especially as compared to something like exercise classes, and it would be nice to have that evidence to offer people that option of care apart from anything else. Here they kind of summarize the aim of the study is to establish the difference in clinical effectiveness and costs of a walking program and a supervised general exercise program compared with usual physiotherapy, which acted as a control intervention in participants with chronic low back pain. So we've got these kind of three arms of the trial: a walking program, a group exercise program, and usual care. So it seems to address like quite a clearly focused issue. We know about the intervention, the walking program, the comparator is usual care. We'll come to the outcomes and the population, but it does seem to address a nice clearly focused issue. And the CASP tool invites us to check whether the trial's been randomized, which is like a really important thing to know if it's going to be useful or not. And yeah, it has been randomized, and they give us lots of information about how that's done, which is good. It sort of increases the trustworthiness of the trial. And also they tell us that that's being blinded for as many people as possible. Just the statistician and the principal investigator were aware of how that was done. So yes, it's been randomized, which means that it is worth continuing to the next question, which is to check whether patients, health workers, and study personnel were blinded. So, as with many physiotherapy trials, the answer to this is, of course, no, they weren't. You can't really give physiotherapy trial unless you know who's getting it, and you can't receive it unless you know what you're getting. So it's not a blinded trial, but they have done their best. The research assistant was blinded to group allocation, and they administered the outcome measures. So it was the assessing was blinded. And the statistician and the health economist were unaware of the group allocation as well. So they've done their best to blind it, which looks good. Nevertheless, of course, we have to say no, it's not a blinded trial. Were the groups similar at the start of the trial? So where's the baseline information? Obviously, we're checking that no group has like a head start if they on another group, and we're also checking that no group has sort of any features to it which might where is the baseline, has any features to it which might kind of make it more disposed to getting better before the other group. I think they report it in the it's here in yellow, I'm sorry. So yeah, they say here there's no significant differences between groups at baseline for social demographic, clinical characteristic or outcome measure scores, so that's great. Yes, they were similar. Aside from the experimental intervention, were the groups treated equally? So let's go and have like a closer look at what each group or each trial arm was actually given. Here's information about what both the walking program and the exercise class were given. And it seems like a kind of good psychosocial sort of package of care. So there's individual discussions, talking about the nature and cause of back pain, addressing any unhelpful thoughts and beliefs, physical activity habits, self-management concepts, that kind of thing. So that's all here. Kind of underpinned by biopsychosocial model, this like lovely little message of hurt does not equal harm. So both groups are getting that. which is really important. And both groups are getting access to getting given a copy of the back book as well. So this is like a really kind of multimodal or complex intervention that works on a like full psychosocial level. But the important thing for this is that both groups are getting the same thing. The walking program is done on like graded principles. It hasn't gone very well. Starting off with sort of 10 minutes, at least 4 days a week, and working up to aiming for kind of 30 minutes, 5 days a week. So it's kind of increasing graded activity. And the exercise classes once per week for 8 consecutive weeks, and also based on graded exercises. So they're both kind of using that graded principle as well. Usual physiotherapy in Ireland by a total of 36 different therapists. They say down here what usual physiotherapy is. It's always really interesting to see. Let's see, we've got 55% of the 77 people who got usual physiotherapy were given stretches, 45% core stability, a bit of strengthening, some stuff on posture. 27% of people advised to stay active for over half of people. So it seems it's like how you'd expect it to look, basically. Let's see, one lucky person got a grade 5 manipulation. A few people got heat and interferential therapy. So that's what usual care is, basically. And I'd say that the groups were treated fairly equally. I didn't go into it there, but they got, I think, quite similar contact times with the therapist as well. Were all of the patients who entered the trial properly accounted for at its conclusion? It was given like a really thorough report of what happens to each patient here without going into all the detail. Yeah, everyone's accounted for. And importantly as well, there's like this intention to treat analysis. So no one's ignored in the statistical analysis either. They haven't just analysed the people who stuck around. So yes, all the patients who entered were properly accounted for at the conclusion. So finally, time to look at the results. Let's have a look at what outcomes were measured first. Where do they report this? Yeah, so they go for the Oswestry Disability Index, ODI at 6 months. So this is pretty standard for it's pretty standard back pain outcome measure. It's valid and it's reliable. It's like internally consistent. It's notable that they've gone for a disability outcome measure rather than pain, which is good because it sort of takes account for the full effect of back pain on someone's life. They've gone for a 6-month follow-up as well, so kind of given it plenty of time to get results. That's their primary outcome measure. It's great that they sort of stipulate what that is, or specify what that is. They also have a look at pain as the secondary measure, along with psychosocial beliefs like fear avoidance and self-efficacy. And they look at the cost outcomes as well. So that's what they're looking at. What did they find? Well, I'm just going to go through the results kind of bit by bit. The first thing that they report is that there were more adverse effects in the walking program intervention. They report that 5 people experienced more back pain and 2 people got groin and knee pain, but were able to continue with the intervention, the walking program. But 7 other people who got increased pain during the walking program weren't able to, and were transferred over to the usual physiotherapy group. So that's like something to bear in mind. Actually, I was a bit surprised by that people in the walking program actually reported more adverse effects than people in the other 2 programs. Nevertheless, or almost kind of paradoxically, adherence was higher in the walking program. Let's see. So let's get into the meat of the results. In all 3 groups, the following things increased. The ODI, pain, and fear avoidance got better. interestingly, back beliefs did not improve. So although there seems to have been, well, people were given this back book and there's been a little bit of back education, that doesn't seem to have sunk in, so that's interesting. And there was a reduction in exercise self-efficacy. So actually over this kind of 6 months of people doing the exercises, doing the physiotherapy, their perception of their ability to change their condition actually decreased, which is a shame, but important to kind of realize. And here's the kind of big take-home message, is that there was no significant difference between groups in the extent of these effects. So all three groups, the walking program, the exercise program, and usual physiotherapy, we find a result that's just about the same across levels of disability, pain, and fear avoidance. And that's even when you kind of adjust for people's baseline physical activity habits and things. So we've got like a pretty similar result to what we saw in the self-study, which is a strong suggestion that a fairly simple blanket intervention causes outcomes that are just as good as usual care with all its kind of different modalities and personalized approaches and things, which is straight away something that should probably stop and give us pause for thought. Let's see. I'm going to skip over the rest of the results, not go into every single thing. So we covered the outcome measures, the primary outcome measure, the results, which were pretty much the same across the board, and they can comprehensively report all the outcomes, so there's no selective reporting, and they stick to their primary outcome measure. They don't try and spin it or anything. So that was probably a good time to go into kind of how large the effect was, and like what are the confidence intervals. And I've stuck this little graph in because they give us all the confidence intervals, but not a graph to interpret it. Basically, this is the ODI here. Down here is no change. Up here is more change. I've got the walking program, exercise class, and usual physio. Probably what you can see on this graph is that the minimal clinical important difference on the ODI is 10. So that's the line across here. And that's the minimal clinical important difference that the authors, Hurley et al., say they're aiming for. And you can see that really none of these programs get near it. Like the walking program might kind of edge up there, but it doesn't really. And that's a pretty conservative estimate of MCID as well. Sometimes you'll see it as high as 50%. So the effect sizes, as they admit here, are small. And it's tempting to see this and interpret the walking program as having been more effective, but these differences are not really statistically significant. We can't be sure about them. They're much of a muchness, really, and they're all statistically significant. So now it's time to kind of ask, will the results help locally? Well, this was kind of what the trial loses in internal validity for having so many different therapists, so many different centres, and so many different kind of approaches. It gains an external validity. It was 5 different centres in Ireland that this was conducted in, so that makes me kind of more confident that it kind of represents the average NHS centre perhaps, and the average NHS patient maybe. Just speaking of patients as well, we can have a look at the inclusion and exclusion criteria up here. So as you'd expect, so patients with back pain of more than 3 months. Again, there's always this thing, never over 65, so they're kind of adults, but not old adults. And people who, crucially, already have low or moderate levels of physical activity. Another interesting thing is that we've had people with radicular pain being excluded, so often you'll see that kind of lumped in with low back pain as if it's the same thing, but it's not. So if someone comes in with persistent low back pain and they have it kind of radiating down their leg, that's not the kind of person who's been assessed in this trial. So these are kind of not massively broad exclusion criteria. You've got like cardiac disease excluded here as well, obviously neurological diseases, and RA is excluded too. So it's fair. They're not massively generalizable in terms of the population, but you can pretty easily spot when someone comes into your clinic and does fit this inclusion exclusion criteria, and there's probably plenty of them. So I'm just going to say, let's see, if you're being kind of generous, they are generalizable, and you don't. So I'll say that. Were all clinically important outcomes considered? Let's see, yeah, especially since we got the cost. There's no objective measurement of physical activity. They tried to use a pedometer, but not enough people used it, and they couldn't kind of get enough data to report it. I'm not like massively fussed about that. I think it was pretty well covered in terms of the different outcome measures, and are the benefits worth the harms and costs. So kind of the proposition of the trial is that a walking program is going to be far less costly and less harmful, or potentially harmful, than some other interventions. And indeed, like, I didn't look at it just now, but the walking program did turn out to be less expensive than usual physiotherapy, as did the exercise program. So in that respect, it is worth the financial cost. Although it's important to kind of note that more people, it seems like 14 people of the kind of, was it 70 or 80 in the walking program, experienced adverse effects, and 7 of them had to drop out. So there's a little bit of suspicion there that walking programs in the community might leave people in a sort of situation where they feel like their back pain isn't being controlled. So I'm just going to say that you maybe can't tell whether the benefits here are worth the harms and costs. So that's it for the CASP trial, and that's it for the what was it called, the Swift trial. I don't think there's anything else to cover really. It's quite nice, just like the self-study, in terms of provoking a little bit of thought or a little bit of discussion about whether our, as I said before, lovely multimodal personalized interventions are any better than kind of more straightforward interventions. I won't say simple, because there was plenty to the walking program in terms of the education that went along with it. I certainly wouldn't say that you should kind of, or personally don't think that the lesson from this is that you should give everyone a walking program and a back book who comes in if they've got back pain. I don't think that would be particularly good care, but certainly plenty to think about in this trial.